Assalamu alaikum wa rahmatullahi wa barakatuh. Today, our lecture will be on the salivary gland. Sorry for recording this on Zoom. It must be on Meet, but I have some circumstances that prohibit me from continue with the Meet. I will continue in the Zoom, and the record will be on your classroom. Our lecture today will be on the diagnosis and management of salivary gland. Before we start with the salivary gland, you should know some physiology anatomy of the salivary gland. As you know, salivary gland, we have two types of salivary gland, either major one or minor one. The major is either parotid, submandibular, or sublingual glands, while the minor one, which minor salivary gland, present in different parts of the oral cavity, like the lower lip, floor of the mouth, buccal, mucosa, and part of the oropharynx and the soft pelvis. As you know, the function of the salivary gland is to provide act as a lubricant, digestive, immunologic, and cleansing properties. Regarding the physiology, we have about 1 liter or half 1.5 liter per day secretions of saliva. Most of this is from the submandibular salivary gland. Starting with the parotid gland, as you know, the parotid gland is located in front of the external auditory meatus, overlying the ramus and the angle of the mandible, and in close relation with the facial nerve, part of the external carotid artery, and the retromandibular vein. And the parotid gland, as you know, has a duct called Stenson duct that emerge from the anterior part of the gland and go more forward over the masseter muscle here, and then go medially, piercing the buccal fat of fat, buccopharyngeal fascia, buccinator muscle, and finally the mucous membrane of the buccal mucosa to be opened on the summit of the papilla opposite to the upper second molar. While the submandibular salivary gland, which is located in the floor of the mouth, and the deep part in the floor of the mouth, and the superficial part is below the mandible, and have two parts, as you know, superficial and deep part, which overlying the superficial part overlying the myohyoid and hyacrosus muscle, and the deep part is deep to the mylohyoid muscle. So the joining point of these two parts is along the mylohyoid muscle, and have the duct which is called Worthen ducts, which emerge from the deep part of the gland and open on the summit of the area in the anterior part of the floor of the mouth. And this type or this duct is prone to retrograde infection by oral flora. This is, as you see here, the deep part or superficial part of the gland, and this is the deep part of the gland. And from the anterior surface of the deep part of the gland emerged the duct that opened in the floor of the mouth, and there is a close relation of the Worthen duct with the lingual nerve. This is how to do a binual palpation of the submandibular salivary gland. One of the index finger in the floor of the mouth, opposite the deep part of the gland, and the other index finger is extraorally below the body of the mandible. And we can do a bimanual palpation to examine if there is an enlargement of the gland or not. Now, finally, the sublingual salivary gland, which is located in the sublingual space beneath the mucosa of the floor of the mouth, and have either many ducts, small ducts, or major ducts, called Bartholin ducts. The small ducts is called ducts of Rivenese, or if it is contain one major duct, it's called Bartholin ducts. And the minor salivary gland, which is scattered in the palate, buccal mucosa, floor of the mouth, and have a secretion of the saliva about less than 1% of the total amount of the salivary secretion. This is as you see here, the sublingual salivary gland. This is the mylohyoid muscle. This is the deep part and superficial part of submandibular salivary gland. Now we go to the classification of the salivary gland disease. We have 8 classifications, either developmental, infection, obstructive, mucus retention, or mucus extravasation. We have also salivary gland dysfunction like salivary or xerostomia, autoimmune disease like Sjogren's syndromes, necrotizing cellular metaplasia, and tumors which may be either benign or malignant. Starting with the cellular which is either acute or chronic. For the acute, maybe either viral infection like mumps, which is caused by paramyxovirus, or bacterial like infection from the Staph aureus, staphylococcal pyogenes, and streptococcal viridans. The chronic, which is maybe either from acute infection of the salivary gland disease that may cause high fever, papillary obstruction due to ill-fitting denture, for example, or maybe due to from the stone of the salivary gland, which causes inflammation, blockage, and dilatation of the salivary ducts. Regarding cellular which is the stone or the formation of the stone or cellular in the salivary duct, resulting in the obstruction of the salivary flow. This is as you see here, stone on the orifice or nearing the orifice of the submandibular duct, working duct, as you see here, and this is the inflammation of the papilla surrounding or on the summit of this papilla. It's also a case or image of occlusal view, and this is the stone of the submandibular salivary gland. For the mucus retention and the mucus extravasation cyst, as like a mucocele, which is caused by trauma, mainly of the lip on the cheek, or the laceration of leading to the laceration of the duct and resulting in the extravasation of the mucus into the connective tissue. For the mucus retention cyst, which is caused by obstruction of the duct itself by cellulite or an scar or tumor, for example, leading to accumulation of this saliva within the gland and mainly affect the minor salivary gland. While for the floor of the mouth, it may affect the sublingual salivary gland, causing what we call the ranula, which is a mucocele of the sublingual salivary gland from either extravasation or mucus retention cyst that give an appearance of a bluish transparency and may sometimes this ranula either bulging intraorally into the floor of the mouth, and sometimes this ranula perforate the muscles of the floor of the mouth, which is the mylohyoid muscle, that causing what we call a plunging ranula as this case. So in this case, the ranula not only in the floor of the mouth, but part of the ranula which are emerging or penetrating through the mylohyoid muscle to emerge from the submental area and causing what we call plunging granula. For the salivary gland dysfunction, we have either xerostomia or salivary. Xerostomia, which means the decreased secretion of the salivary gland, which is a subjective sensation of a dry mouth, and may be associated with either affecting of the salivary gland hypofunction, which may be either primary or secondary. For the primary one, which means that is a hypofunction of the salivary gland, like, for example, maybe a Sjogren's syndrome, or maybe secondary due to a disease or some drugs like anticholinergic drug that cause the dryness of the mouth, like for example pyrocarpine. The opposite of xerostomia is talism, or what we call it sialorrhea, which is the excessive salivation that may be mild, intermittent, or continuous, drooling of saliva. We have many causes, maybe ill-fitting dentures, teething, for example, mostly in childhood, heavy metal poisoning, or medicines like cholinergic agonist. As you know, cholinergic agonist causing excessive salivation, and cholinergic antagonist causing xerostomia. Maybe either transitory to mild and no treatment is required. In some cases, we can start with anticholinergic drugs like atropine or proton pump inhibitor to prevent excessive secretions of saliva. And some authors or some of the evidence starting with the intraglandular injection of Botox to decrease the secretions of saliva. For the Sjogren syndrome, as you know, it is a symptomatic disease causing dry mouth, which may also associated with autoimmune disease or autoimmune exocrinopathy. Maybe either primary or secondary, according to it. Whether it is the primary affecting the salivary glands, it's called Zika syndrome. Those patients have dry mouth, dry eye, or maybe secondary due to another connective tissue disease, or this disease, or the Sjogren syndromes, or xerostomia, maybe secondary due to other connective tissue disease, for example, rheumatoid arthritis or systemic lupus erythematosus. For the management of xerostomia, first we have to use a periodic use of artificial tears, artificial saliva to keep the mouth moist. Also, we have some drugs like pilocarpine and the daily fluoride application to decrease the incidence of carious lesion. Also antifungal, because as you know, one of the function of the saliva is to wash out any viruses or fungal infections or bacterial infections. So we can start with antifungal. Prednisolone in case of autoimmune diseases, secondary one, like rheumatoid arthritis. And also should it be treated with multidisciplinary team, including rheumatologist, ophthalmologist, oromaxillofacial surgeon, and general dental practitioner for the motivation of the patient. And this picture is the cyelogram, showing this what we call it branches tree, fruit laden branches tree, or what we call it punctate telangiectasia, due to obstruction or destruction, sorry, of the ducts, leading to accumulations of contrast media in the lacunae or in the alveoli of the glands. For cellulosis, which means non-inflammatory enlargement of the gland, which may be affected mostly the parotid gland, and the condition is frequently associated with underlying problems or systemic disease, maybe endocrine, maybe nutritional, maybe neurogenic. For the endocrine disease, maybe diabetes mellitus and diabetes insipidus acromegaly. For the nutritional, maybe due to alcoholism or cirrhosis. And for the neurogenic, maybe antihypertensive drugs are some of the sympathomimetic drugs that used to treating asthma, which called non-inflammatory enlargement of the salivary gland. And this considered as one of the indications of open biopsy from the parotid glands. For the necrotizing share metaplasia, which is local destructive inflammatory condition of the salivary gland, and it is the result of that lead to local infarction, and this infarction will later on considered as a cause for the ischemia and necrosis, and it is mimic the malignant condition clinically and microscopically. We have many predisposing factors like traumatic injuries, dental injections, ill-fitting dentures, and upper respiratory tract infection, and some of the previous surgery in the area. Mostly, this condition is self-limiting condition. It may be treated by irrigation with hydrogen peroxide or normal saline, and it will heal in 6 or 8 weeks by secondary intention. For the tumors of the salivary gland, we have either the benign one or malignant one. The most common benign tumor of the salivary gland affecting either parotid or minor salivary gland may be the pleomorphic adenoma. So in this neoplasm, the gland will enlarge and displacing the glandular tissue and producing what we call it grasping finger appearance. And FNA is an indication for diagnosis of this type of tumors, and the treatment of choice for such condition is the superficial parotidectomy for the parotid gland, or if we have a large tumor, we can go for extracapsular dissection, which means that we leave a cuff of normal parenchyma of parotid tissue about 2 millimeter with normal parenchyma around the tumor to get rid of any daughter cells that may adhere to the surgical bed and result in the recurrence of the tumor. This is the access for the surgical access for the salivary gland, parotid salivary gland, by what we call modified Blair technique, starting from the external meatus anterior to it and behind the ear to the muscle region and passing inferiorly to the submandibular region, about 2 fingers below the angle of the mandible. We have also another modifications for the incisions of the parotid region. Any type of the incision we can use it for the superficial parotidectomy. For the Wharton tumor, which is the second most common benign tumor of the parotid gland, mostly affecting male, mostly bilateral, and maybe associated with smoker patients. For the malignant tumor, we have also some of the malignant conditions that may affect the salivary gland, for example, either by adenocystic carcinoma or mucoepidermoid carcinoma, and the drug or the treatment of choice in this condition is the surgical excision of the tumor with safe margin, and irradiation is beneficial in controlling metastasis of the disease. Here, there's some of the descriptive finding between the benign and malignant tumors. When you see some fixation or nerve injury or nerve paresis before you go to the surgery, suspect that this lesion is malignant. And also the growth of the tumor in malignant condition may be faster or rapid than slow growth in benign condition. Also, there is some dilemma between the how to differentiate between the benign tumor and the low-grade malignant tumor, because low-grade malignant tumor also may behave as a benign tumor. So the diagnosis mainly depend on the FNA, and if the FNA is not conclusive, we can go for the surgical excision by superficial parotidectomy and then submit the specimen for the histopathological examination to differentiate between these types of tumors. How to manage those cases? First, as you know, we have a sudden history of painful swelling or short duration, such as there is an infection. Recurrent painful swelling with long duration suggests a chronic infection. Slowly growing swelling, it's maybe a mucocele, or slowly growing NSTD may be a benign tumor, and rapid progressive tumor may associated with malignant condition. For the clinical examination, as you know, as any type of clinical examination, we started with the fluctuancy of the mass, which is firm, tense, and tender, and not movable, suggests that is maybe infected or maybe obstructed salivary gland. and firm, not tender, and movable suggest benign condition, while indurated and fixed suggest malignant tumor or malignant condition in a clinical examination. For the investigation, we have many diagnostic imaging process to diagnose the conditions, starting with the conventional radiography like salivary, as we see in the Sjogren syndrome, in punctate cell angiectasia. But we have a contraindication for this condition, including allergy to iodine compound, because the contrast media will be iodine. And in case of acute suppurative cellulitis, salivary is contraindicated. While for the other treatment options is the observation. As you know, the observation, when there is a normal salivary gland, it's often described as having a leaflet tree appearance. The salivary calculus or stricture or other obstructions appear as radiolucent lesion in the radiograph, and as I said before, the Sjogren syndrome appear as cherry blossom or branches fruit laden tree appearance. Also, we have another technique for diagnosis of salivary tumors, which is the radionuclide salivary imaging, including scintigraphy with the using of technetium-99, and also PET scan can be used for detection and localization of salivary gland tumor. Ultrasonography also can be used to differentiate between intragrandular and extragrandular masses and demonstrate the presence of solid cystic masses and cellular leaf. And the FNA for biopsy is indicated in this condition, and any condition we can use the ultrasound or FNA guided ultrasound, ultrasound guided FNA to take a biopsy from the gland. This is the CT scan, which also can be used. And this is here we can see the stone inside the parenchyma of the parotid gland. This is the parotid gland, normal condition, and this is the affected condition when there is some of the hyperdense mass inside the gland, which indicate there is a stone in the parotid salivary gland. This is the CT scan, axial view. We can see here, as I said, the calculus or calculi or cellular leaf inside the parotid gland. Also, we have another procedures or management procedures which is called endoscopy, which means there is we insert inside the duct to make some of the intragrandular or intraductal manipulation of the stone to type of removal of the stone from the gland or from the duct, which is called salivary gland endoscopy. For the laboratory investigations, we have many laboratory investigations, including the serum level of amylase. If there is any antibodies for the rheumatoid factor, maybe ESR rheumatoid factor. On CBC to see the level of leukocyte in case of infection. And the smears and culture and sensitivity are also valuable to for appropriate antibiotic to be employed or to be used to treat the infectious or infection condition. For the biopsy, we have also the fine needle biopsy, fine needle aspiration biopsy, and the serum material will submit it to histopathological examination. We have core needle aspiration biopsy, and also we have some of the excisional and incisional biopsy, but incisional biopsy is contraindicated in the parotid region because of the possibility of the injuring the facial nerve and the possibility of what we call it tumor seeding inside the parotid. So the only indication for incisional biopsy is in the parotid region is in case of cirrhosis, TB, sarcoidosis, and in case of lymphoma, we can go for incisional biopsy from the parotid region. The surgical management, as you see here in this case of a mucocele in the lower lip, is the excision of the mucocele with underlying minor salivary gland. because this minor salivary gland, if it is not removed, it will again collect the saliva inside the tissue or inside the gland in case of ductal obstruction, leading to recurrence of this mucocele. So the treatment of choice is the removal of the mucocele with its underlying salivary gland, minor salivary gland. For the ranula, we have two techniques. Either if it is first technique is the marsupialization, or what we call deroofing, which is the opening on the top of the ranula and suturing of the lining of the ranula with the floor of the mouth, leading to draining of the saliva into the oral cavity. But this condition have what we call a recurrence rate of about 85%. So the other treatment option is the removal of the salivary gland at all, the sublingual salivary gland at all, by removing of the ranula and the sublingual salivary gland with recurrence rate, less recurrence rate. For the ductal obstruction, we can use sorry, for the ductal obstruction, we can use another type of removal, which is transoral sclerotomy of submandibular stone. It is in the anterior part or the distal part of the duct, and in the parotid area of the duct is of the stone anterior to the anterior border of the masseter muscle. We can use it by semilunar incision in front of the papilla. It is more posteriorly. We can remove the gland at all, as you see here. In this condition, in the anterior part, we can remove by transoral approach. Thank you very much, and sorry again for to present this lecture in the Zoom, because I have some of obligatory condition that prohibit me from giving interactional or lecture with you. Thank you again.